Good afternoon. I'm Tony Das, an interventional cardiologist from Dallas. I serve as the Regional Medical Director for Peripheral Vascular Disease, Cardiac Innovations, and Digital Health at the Baylor Scott and White Heart Hospital. I also founded Connected Cardiovascular Care Associates, which is a digital practice of cardiology in Dallas, Texas. These are my disclosures, none of which are essentially irrelevant to this presentation. The title of my presentation is Laser Still Relevant in PVD? Short answer is yes. So in 2020, how is laser used? On which lesions and why would you consider using it? I'm going to just describe a couple of different types of lesions and give you an idea why you might consider using EXCIMER laser in these territories. Calcified lesions, diffuse disease, no stent zones, certainly in-stent restenosis, and thrombotic disease are places where you would consider using laser. Question is why? Well, the lesions that we just described can be affected by laser in a variety of different ways. We'll get into laser physics, which will help you understand why you can see these different changes. First of all, calcified tibial or SFA disease, particularly tibial disease, can be treated with high energy 0.9 millimeter laser in the tibials, changing compliance in those territories. Also in the SFA with larger laser catheters, the same thing can happen with calcified or diffuse disease using 1.7 to 2.5 millimeter EXCIMER laser catheters. And it's been proven in previous studies that stent use is decreased by using atherectomy in these territories. In addition, common femoral and popliteal non-stent zones traditionally, laser atherectomy increases the size of the lumen and decreases the likelihood of stent usage. For in-stent restenosis, it is the approved device for in-stent restenosis with devices that go up to 2.3 millimeters, and there's an excellent results for the EXCITE trial for this, and we'll go over that in a few minutes. Thrombotic lesions also have direct platelet effect, and we'll show you some examples of why that's important. So first of all, diffuse tibial disease. One of the things that laser does is it uncovers the lesion. Here's an example of a case where there looks like there's really no tibial flow at all. Laser atherectomy actually vaporizes the plaque, uncovers a lesion, and reveals that there really is 3-vessel runoff, and with balloon angioplasty you can get a very nice result without having to place numerous stents. Why does it do this? How does laser really work in these territories? Well, EXCIMER laser, particularly at 308 nanometers, has specific physics properties, including photochemical effects, photothermal effects, and photomechanical effects. So what does that mean? Well, photochemical effects mean that the laser catheter itself and the bubble that it creates dissolves molecular bonds. Carbon-carbon bonds are broken. That's why when you do a laser pass, you frequently will see a much larger lumen than the size of the catheter. Photothermal effects, including the creation of some mild thermal energy, is obviated by saline flush, which is a technique to reduce dissection and heat generation. And then photomechanical effect, which is the actual rapid bursting of the forward bubbles that are created by laser, creates a kinetic energy that breaks up plaque as well. So from a physiologic standpoint, there are actually multiple effects of laser on these lesions. So for in-stent restenosis, which is a common use of laser atherectomy, the interaction of laser with the in-stent restenosis soft and friable tissue does a very good job of vaporizing that tissue because of the tissue density and also the absorption spectrum of the 308 nanometer laser. The EXCITE trial proved this. In fact, study enrollment was stopped after 250 patients because there was an improvement in early efficacy by the Data Safety and Monitoring Board. In fact, after 169 patients in the EXCIMER laser and balloon angioplasty arm were enrolled with very long lesions up to almost 20 centimeters, with almost a third of those being chronic occlusions and very high procedural success, the 6-month TLR was 73%, and the PTA alone was 51%. 30-day MACE rates were also noticed to be dramatically lower, 5.8% with EXCIMER laser and 20% with PTA alone. So in light of this, it was felt that this was a very useful and very efficacious therapy for patients that had in-stent restenosis, reducing their 6-month freedom from TLR dramatically and also introducing their major adverse event rates. So what about thrombus? Why is thrombus considered a useful type of lesion for excimer laser? Thrombus, as you can see in this case, has a diffuse nature, reducing the flow and making it almost impossible to tell where the lesion is in a occlusive vessel like this. What laser does is that it essentially uncovers where the real lesions are. As you can see, after this pass and this long segment occlusion in a patient with atrial fibrillation and an embolus to her leg, that the lesion shows it to be closer to the popliteal with really only minor disease in the SFA, and therefore reducing the use of stent and the length of other devices. And this is the final result. So what exactly does laser do to thrombus? Well, because of the science of the laser effect on thrombus, what we know is that the spectrophotometric scan of thrombus reveals that at 308 nanometers, which is the wavelength of lasers, that the absorption of the thrombus material is highest at this wavelength, thereby vaporizing the plaque with the most efficacious passes. In addition, there's a secondary effect where platelet aggregation is reduced. This is an example of a in vitro experiment where excimer laser at higher and higher energies is placed in the aggregated platelet bath, and you can see that with placebo there's very low platelet aggregation, and as you can get more and more energy to the platelets, that the laser dissolves those areas of aggregation and uncouples those platelets, which is something we see clinically very typical for laser interaction with thrombus. So in conclusion, excimer laser is extremely relevant to PVD. The diffuse disease, including calcified, tibial diffuse disease, thrombotic disease, and in-stent restenosis, can be treated quite safely and with excellent efficacy with laser atherectomy. Thank you very much for your attention.